All right, so this is a pediatric anesthesia case report on a Down syndrome patient with atlantoaxial instability by Deanna Steinhardt and Connor Beretta. Here's our outline. We will review an introduction to Down syndrome pathophysiology and clinical findings. Then we will present a case study and consider the anesthesia implications. So Down syndrome, also known as trisomy 21, is the most common chromosome abnormality. It results from the presence of a third chromosome on chromosome number 21. Patients with this disease can present with dysmorphic features such as upslanting palpebral fissures, epicanthal folds, flattened nasal bridge, flattened occiput, and brachycephalic head shape. Short, broad hands with transverse palmar crease and hypotonia. Diagnosis is confirmed with karyotype analysis. Congenital anomalies of almost all organ systems are associated with Down syndrome and is the most common cause of intellectual disability. Most cases are mild to moderate. They also commonly present with low birth weight and short stature. CNS effects include seizure, strabismus, and hypotonia. They are also likely to develop dementia or Alzheimer's as they get older. Increased risk for upper airway obstruction due to hypotonia, high arched palate, macroglossia, and micrognathia. Lastly, subglottic airway is generally decreased. This can be related to stenosis. I have pictured here grades of stenosis which may help provide an idea of how difficult their airway can be. Cardiovascular clinical findings include congenital heart disease, increased risk for pulmonary hypertension, atropine sensitivity, and bradycardia with sevoflurane induction. 50% of Down syndrome patients have single or multiple congenital heart defects. Of these defects, atrioventricular septal defects are the most common, followed by ventricular septal defects, persistent patent ductus arteriosus, tetralogy of Fallot, and others. Gastrointestinal anomalies are also common, including gastroesophageal reflux, intestinal atresia, anorectal malformations, and Hirschsprung's disease. Atlantoaxial instability, pictured here, can have the severest impact on neurological function. It can present as asymptomatic or can present with cord compression symptoms including neck pain, torticollis, and gait abnormalities. Subluxation of atlas C1 and axis C2 joint can cause spinal cord compression with resultant sensomotor defects as well as loss of bowel and bladder control, which would require immediate surgical stabilization. Also, hyperextensibility/flexibility of joints, dysplastic pelvis, and clinodactyly can be present. Clinical findings for immune/hematologic functions can include immune deficiency, leukemia, and neonatal polycythemia. Endocrine dysfunction most pertinent to anesthesia includes thyroid dysfunction and low circulating catecholamines. The case study we found was on a 12-year-old male child with Down syndrome with complaint of progressive weakness on the left side of the body after suffering a fall. He is presenting for anesthetic management for an MRI scan. Past medical history includes esophageal atresia as a neonate, which has been surgically corrected. His physical exam shows that he was poorly nourished, moderately built 20-kilogram boy. Face has mongoloid presentation with upward slant of eyes, small nose, and flat nasal bridge. Hands show clinodactyly with a simian crease and sandal gap between great toe and the rest of the toes. He presented with cervical collar in situ. Vital signs show heart rate 90 with blood pressure 90/60. CV and respiratory exam revealed no gross abnormalities. Nervous system exam showed hypotonia and left-sided weakness. Muscle power was approximately 2/5 in the left upper and lower limbs. Airway revealed macroglossia with prominent upper incisors. Noted was limited neck mobility due to cervical collar placement. And now I will turn it over to Deanna.
As far as imaging, This patient only had a prior echocardiogram from infancy, which showed presence of a patent ductus arteriosus. His most recent echo showed normal cardiac physiology. X-ray of cervical spine showed dislocation of atlantoaxial joint space, and MRI was unable to be obtained, leading to the patient's current presentation for anesthesia to obtain MRI. The anesthetic plan for this patient involved inhalation induction utilizing oxygen, nitrous oxide, and halothane, which was increased gradually for a total of 3%. To prepare for possible difficult airway, fiber optic equipment was made available for possible conversion to endotracheal intubation. After adequate anesthesia depth was achieved, neuromuscular blockade was produced with atracurium 10 milligrams. The airway was successfully secured using an LMA size 2, and a bite block was placed to prevent the child from having dental damage and airway obstruction. When securing the airway, neck alignment was maintained in neutral position with cervical collar in place, and anesthesia was maintained using halothane, oxygen, and nitrous oxide. The only complication encountered was a single episode of frequent ectopic beats, and that was treated with 30 milligrams of lidocaine IV, and there were no other complications throughout the case. At the completion of imaging, inhalation anesthesia was discontinued, and neuromuscular blockade was reversed using neostigmine and glycopyrrolate. The LMA was removed after the patient was fully awake, and repeat neurologic exam findings were consistent with the pre-anesthetic assessment, showing no change from baseline had occurred. So for these patients, there are a lot of anesthetic recommendations and steps that the CRNA can take to optimize the anesthetic experience for the patient and provide safe anesthesia. First, the patient with Down syndrome is more likely to suffer from anxiety and agitation when placed in unfamiliar environments. This may lead to combativeness and physical resistance. To mitigate this, it is recommended that the pre-anesthetic assessment be performed with either the patient's caregivers present or with a child therapy specialist present. CRNAs should try to explain what is happening to the child in language they can understand. Promoting a calming and encouraging environment can help to alleviate anxiety and promote trust in the anesthesia provider, as well as enhance the overall anesthesia experience for both the patient and the family. If efforts to reduce anxiety are still met with resistance, PO administration of midazolam 20 to 30 minutes prior to procedure or intramuscular ketamine can be used to help anxiety, and inhalation induction can be used to reduce the patient's resistance. Premedication should be administered with caution in children with severe obstructive sleep apnea. Children with Down syndrome are also at higher risk for central nervous system disturbance, as they are more likely to suffer from cervical spine instability. Unstable spine can lead to neurologic deficit, and a thorough neurologic assessment prior to anesthetic administration is necessary to determine a baseline from which to compare postoperative neurologic assessment findings to. This allows the CRNA to pinpoint defects that may not have been present prior to anesthetic intervention. One of the most important features of anesthetic care for the patient with Down syndrome involves the airway and respiratory systems. These patients often present with congenital abnormalities, which contribute to higher risk for difficult airway and respiratory management. Both the upper and lower airways pose anesthetic risks due to hypotonia, relative obesity, smaller upper airway, stenotic anomalies, and pulmonary hypoplasia. Patients with Down syndrome often suffer from subglottic stenosis, which may prevent insertion of an endotracheal tube. CRNAs are advised to use endotracheal tubes 2 sizes smaller than those commonly used for patients without Down syndrome of same age and weight to prevent difficulty with insertion. If endotracheal intubation can be avoided, or if the procedure is shorter than in duration, LMA insertion can be used to secure the airway with minimal neck manipulation. However, these airways may prove insufficient for the patient requiring higher airway pressures and should be reserved for patients with lower risk pulmonary profiles in shorter cases if possible. As in all children, air leaks less than 25 centimeters of water pressure must be demonstrated. These patients are also at higher risk for airway obstruction due to irregular oropharyngeal anatomy. Having the necessary equipment for emergency readily available, including multiple sizes and types of airways, blades, tongue blades, oral airways, nasal airways, and surgical airways, closely following the ASA airway algorithm for difficult airway encounters, and close monitoring for obstruction after airway removal can help with prevention and early assessment of difficulty breathing and from obstruction to provide the best outcome for this population. The cardiovascular system of Down syndrome patients is often complex. Patients may be born with congenital abnormalities, may present for cardiac surgery, or have a history of cardiac surgery repair. A thorough cardiac history must be obtained from the patient and/or the patient's caregivers to determine anesthesia risk. In higher risk cases, an official cardiology evaluation and clearance complete with diagnostic imaging and lab assessment may be necessary prior to administration of anesthesia in these patients. An important aspect of inhalation anesthesia management in these patients involves the administration of sevoflurane. In a study of over 11,000 pediatric anesthetics, 28% of pediatric Down syndrome patients experienced sevoflurane-induced bradycardia, compared to 9% of the control group. In these instances, reduction of sevoflurane and administration of glycopyrrolate or atropine was necessary to reverse the bradycardia, and CRNA should prepare for this phenomenon by having these rescue medications available or to avoid sevoflurane use if possible. The gastrointestinal system of these patients presents with a higher incidence of reduced peristalsis and increased incidence of reflux, making these patients prone to aspiration. Administration of sodium bicitra, metoclopramide, and Pepsid prior to induction can help to reduce gastric acidity and stomach contents prior to airway manipulation. In terms of the musculoskeletal system of these patients, as we have discussed earlier, these patients often suffer from cervical spine instability. In these circumstances, it is important for the CRNA to understand the risks that general anesthesia pose to this population. Manipulation of the neck and upper body anatomy risks subluxation of the atlantoaxial joint space during laryngoscopy and positioning. It is important that the CRNA avoid forceful flexion or overextension of the neck during direct laryngoscopy. Use of video laryngoscope in high-risk patients should be considered to avoid musculoskeletal manipulation and to minimize damage to the airway if possible. In patients who present with symptoms of instability, such as neurologic deficits, paresthesia, trouble walking or moving extremities, cervical spine precautions with the use of a cervical collar should be considered to prevent further damage of the nervous system. If symptoms are new and unknown to the surgical team, delay of surgery may be necessary until a complete cervical spine evaluation can be performed. And as we discussed before, the use of an LMA in cases that qualify can help to reduce neck manipulation and should be considered for these patients. In patients who do not present with symptoms of neurologic deficit, routine radiologic imaging is not indicated. The hematologic system of the Down syndrome patient, especially that of the neonate, commonly presents with neutropenia up to 80%, thrombocytopenia up to 66%, and polycythemia up to 34%. In cases where white blood cell count is high, patients can be at higher risk for stroke and thrombosis. In these patients, plasmapheresis may be indicated to reduce the white blood cell count to safer levels. Preoperative CBC may be indicated to identify the need for red blood cell or platelet transfusion to reduce risk of bleeding and anemia during operative procedures. As far as the endocrine system is concerned, patients with Down syndrome often have low circulating volumes of catecholamines. This can make them more susceptible to the effects of anesthetic agents. Another thing that CRNAs must be aware of and screen patients for is the use of over-the-counter medications. Many alternative therapies exist which are marketed for individuals with Down syndrome, which are meant to treat or address the cognitive effects of Down syndrome. It is important to assess these patients for any medications and alternative therapies they may be taking, as they could interfere or interact with the anesthetic plan and necessitate redirection of the anesthetic management. In summary, there are many unique characteristics that the patient with Down syndrome presents with which must be investigated and considered by the anesthesia provider to provide safe anesthesia. CRNAs should be well informed of the risks associated with each type of anesthetic used for these patients and be prepared to prevent and mitigate common challenges that these patients may experience while in our care. Careful consideration of the airway, cardiovascular system, and stabilization of cervical spine are key elements of safe anesthesia management for this population, and the prudent CRNA should thoroughly assess each system to optimize the anesthetic experience for the patient. Here is a list of our references, and thank you for listening.